opportunity to this little discussion and talk. Obviously, I'll present some information, but I'm very interested in the questions that come up from the members of the community. So again, my name is Keith Dixon. I'm a sleep disorder specialist. I've been practicing sleep medicine for a little over 20 years. I did the math this morning and realized I've been in healthcare coming up on 39 years, believe it or not.
Oh my goodness.
I don't know how that happened. But most of my career has been spent dealing with sleep disorders, people who have sleep disorders. We are going to focus today a little bit on snoring as an entree to a bigger discussion. Snoring is obviously just a sound we've all heard before in our lives, from friends, loved ones, sometimes from ourselves. We wake ourselves up sometimes with snoring. But we're going to do a little bit of a deep dive. We're going to start on the surface a little bit, and then we're going to go fairly deep into snoring. So I guess you could really say hello to snoring. Let's go ahead and get started. So, what should we all know about snoring? Yes, snoring alone is just noise, although I'm sure many bed partners would dispute that description. Sometimes there's collateral damage where bed partners can't sleep, and it can be obviously annoying. But from a clinical standpoint, from someone who's snoring, it's possible that it's just noise. The million-dollar question really is, what is the cause of snoring? What's behind it? Is there anything else going on beyond just snoring? So there's probably two things that are more important than anything else, right? What happens with the blood oxygen saturation? What happens with your oxygen level during sleep? Is it maintained, or are there issues where the oxygen is going down as a result? And then, are there interruptions that are occurring in sleep itself? Starting with snoring, maybe something beyond that's going on, but we'll talk about that in depth. Before we jump in, let's talk just a little bit about sleep. All right, we call it sleep as if it is a monolith. It's just one thing, either you're awake or you're asleep. But the truth is, sleep is a multitude of different things. You can call them stages of sleep. There's a cycle that we go through in sleep. We start off in light sleep. We move on to, let's call it intermediate level sleep, where we probably spend most of our time. Then we go into deep sleep, usually, right? So that's the sequence, light sleep, intermediate, and then deep sleep. And then we go into a stage of sleep that's very interesting and in some cases very strange, but this is where we have our most vivid dreams. This is called rapid eye movement sleep, or REM sleep. Rapid eye movement sleep, during that time, the brain activity can be just as high as when we're awake. In certain instances, there's wild changes in blood pressure and heart rate. There's a lot going on during that stage of sleep. It's important for memory, important for learning, important for mood regulation. All kinds of things are happening there. So when we talk about sleep, it's really a multi-layered kind of a thing where, as we go through the different stages of sleep, different things happen. And the purpose, of course, of all of it, in the order that it's in, and the percentages of the different types of sleep, the idea is that once our sleep period is done, our body is restored and ready to take on the day. So, snoring, back to snoring, the anatomy of snoring, right? So here you see three illustrations. On the top, we see normal breathing. You can see the little blue arrow going through the nasal cavity, past the back of the tongue and down into the lungs. The second illustration can really be split into two different things. I could have done two slides here, sorry, two illustrations here in the middle. So it says snoring and partial airway obstruction. In a way, snoring is partial airway obstruction. That is true. But there's a form of partial airway obstruction that's separate from snoring, whereby there's disruption in sleep itself or a disturbance in oxygen levels, right? So this is where you can get beyond snoring and start having clinical consequences of this. We can call it resistance in the airway, this vibration that occurs in the airway. And then the last, on the bottom, last illustration, shows what we all hear about, right? Apnea, absence of breathing, due to complete obstruction of the airway. But the truth is, apnea is not the only thing that's really problematic about these partial airway obstructions. Depending on the number and frequency and what happens with the oxygen, can be just as destructive and problematic as the complete airway obstruction apnea events. So snoring can be just noise, that's possible. But it can also be a warning sign of something far more serious, far more dangerous, right? So an umbrella term that I use is sleep disordered breathing. So, and sleep disordered breathing has many types or names, right? Most people will call it just sleep apnea. But there's also, before you get to true sleep apnea, there's something called upper airway resistance syndrome. So this talks a little bit or speaks a little bit to these partial airway obstruction events. These events can be subtle. They can be more common in people who are not overweight. Snoring, airway resistance, sleep disordered breathing is not just a disorder for people who are overweight. It really comes down to a multitude of factors. The bottom line is the shape of the air. What is the shape of the airway in the back of the throat? Defined by the tongue, the soft palate, the uvula, and surrounding structures. So when we talk about sleep disordered breathing, there's upper airway resistance syndrome, sleep apnea, also known as obstructive sleep apnea, but the full complete name of this is obstructive sleep apnea hypopnea syndrome. The hypopnea refers to these partial closure events. So sometimes people try to diagnose themselves or diagnose their loved ones, and they say, well, I saw a pause in breathing, or I didn't. So you have sleep apnea or you don't. There's no way to really see upper airway resistance or these hypopneas or partial airway closure events. So by looking at someone, you can't say whether they have a clinical syndrome or not. It's really possible to do that. Testing is required in order to get there. We'll talk a little bit more about testing later on. But as far as sleep disordered breathing goes, these are some of the names we use to describe it. So how common is this problem? You can see here, and this is data from 2020. It shows men, women, and then children, and how many people are snoring. So you can see a vast number of people are snoring, but the question is, how many of them actually have the clinical syndrome that may be related to this? So that's a question that's still being looked at, and there's a wide variation. Some people say anywhere from as low as 20% of this population to as high as 70%. But it's hard to say because so many people go undiagnosed. They haven't gone through testing, and so it's hard to know exactly what's out there. This part, we know fairly well how many people are snoring. There's obviously quite a few. So again, just to take a pause here, key point, not everyone who snores has this obstructive sleep apnea hypopnea syndrome, right? That's a clinical syndrome where health can be, the overall health can be affected negatively. The rough number is that half of people who snore have obstructive sleep apnea hypopnea syndrome. When you take all the different studies into account, of course, that number changes with different populations of people, right? But overall, we might say that's roughly half. We talked about snoring and not being able to predict exactly what's happening with someone. But the other part of it is that how loud the snoring is also not a good predictor. Sometimes people can snore loudly and their oxygen levels are just fine. Their sleep quality is just fine. If you're listening to it, it might not be, but obviously that's something that requires testing to figure this out in terms of predicting the presence of the syndrome. So again, symptoms are widely variable. This is one of those disorders where there's so many different pieces to it. The symptoms associated with it, it varies a lot from individual to individual. Here are just some of them. This is not a complete list by any means. And some of the things are obvious, right? If you don't sleep well at night, you're not breathing well at night, yes, you may be tired or sleepy or fatigued or feel low energy during the day. But in addition, there are some things that are not necessarily intuitive. And one of them that people struggle with, and some of my patients struggle with, is difficulty initiating sleep. You wouldn't make that connection necessarily because you haven't started snoring or having pauses in breathing yet. But part of this syndrome is kind of an overstimulation of the sympathetic nervous system. The sympathetic nervous system is that portion of the nervous system that is, you could call it the fight or flight portion of the nervous system, right? The part of the nervous system that tenses your muscles, dilates your pupils, gets you ready for action or an emergency. A very simple way to state it is just your adrenaline level is high. Now, initially, when studies were done on this part of the nervous system for people who have this disorder, the idea was, well, it makes sense that during the night, it would be elevated. That makes sense, right? If you're not breathing or it's almost like an internal strangulation that occurs, yes, adrenaline may be released, and that makes sense. However, what we found was that this portion of the nervous system was elevated 24 hours around the clock, which then triggers, it's almost like a maladaptive mechanism where the body's trying to prevent you from sleeping in the first place. So people can have trouble not just with maintaining sleep due to awakenings from pauses in breathing and snoring, but also difficulty initiating sleep to begin with. Another one that's not necessarily intuitive is nocturia. What we see in our patients is you're urinating more frequently in the middle of the night when you're supposed to be sleeping as opposed to daytime. You know, I've had patients come in where waking up every hour or 2 hours. In the daytime, they don't urinate more than every 4 or 5 hours. So something specific going on during sleep that's driving this. And it is, in fact, this syndrome. It causes multiple derangements in hormones that cause us to void or urinate more during the night. Another warning sign. So snoring is an obvious alarm or warning sign. All of these are also warning signs. Waking up to urinate. Headaches. So usually people think about headaches upon awakening. Commonly that's associated with elevated carbon dioxide levels. You know, we talk about oxygen all the time. But, the flip side of not breathing for periods of time is, yes, you lose oxygen, but also you maintain or hold on to carbon dioxide, which instantly is dissolved in the bloodstream, makes the blood more acidic, and can trigger headaches. But we also know that people with migraine headaches, which can happen really any time of day, they're more likely to have migraine headaches or various forms of headaches, which can occur at any point during the day on the basis of poor sleep, poor oxygenation, dioxide levels, changes in hormone levels, and so forth and so on. Also, brain fog, difficulty focusing, trouble concentrating, attention deficit, all these things can be associated with this syndrome. Again, not a complete list. Here's more: mood changes, irritability, anxiety, depression, even gasping and choking in sleep. That's obvious. Another one that's really important is weight gain. So obstructive sleep apnea seems to operate in a way that it almost traps you, right? So weight gain can be a cause or trigger for obstructive sleep apnea, but the reverse can also be true to some degree, where the obstructive sleep apnea, because of changes in hormones, it leads to weight gain through a slowed or dysfunctional metabolism, right? So in some cases, it can be part of this, what we call metabolic disorder, right? So, and these are some of the things associated with this, the metabolic disorder: prediabetes, fatty liver disease, right? But some things, again, this is another area where some of the clinical signs and findings due to or associated with obstructive sleep apnea, these aren't things that are intuitive or obvious. Gout, for one instance, right? So I had a patient in their 20s once, and no one could figure out why this 24-year-old was having just gout over and over again and had to be placed on high dose medications to prevent gout attacks. It turns out this young man had severe obstructive sleep apnea syndrome. Again, where the blood was becoming acidic in association with CO2, changes in uric acid led to gout formation, gout attacks. Fatty liver disease is can be a direct result of obstructive sleep apnea alone, without any other contributors. Hypertension, the same. Obstructive sleep apnea can increase risk of blood clot formation really anywhere in the body. And so you see all of these different things. The eyes can be affected, the heart can be affected. Different parts of the body that don't seem to be directly connected to the airway can be affected by this disorder, because we have to go back to a central idea. And that idea or understanding is that there is not an organ system or a cell in your body that doesn't need a normal level of oxygen for normal function. And so what you may end up with are things that seem to be completely disconnected that actually have kind of a central explanation, right? And that explanation can be obstructive sleep apnea syndrome. Polycythemia along the bottom really just refers to an increase in the number of red blood cells, right? It's red blood cells in excess in the bloodstream. The idea there is, well, what happens if you're losing oxygen at night? Of course, your systems, your internal monitoring systems, you could say, are aware of this low oxygen. And how does the body respond? It responds by making more cells that carry oxygen. However, this is problematic, right? It makes the blood, you could say, simply more sludgy, where circulation is negatively affected. And the results of this can be catastrophic. So, in terms of testing for obstructive sleep apnea, when I started in sleep medicine, there was really only one option, and that was you come into the sleep center, you get everything from EKG to EEG to monitoring pretty much you could say most of the body, right? And that's why they call it a polysomnography or polysomnogram. You're monitoring multiple systems to figure out what's going on. It's actually a great test because so many things can be diagnosed and understood on the basis of this test. However, there is an option for, and this is in uncomplicated cases, where a home device, a very simplified, pared down version of this sleep study can be done in the home. Usually there's three pieces to this. An oximeter looking at oxygen levels through the nail and the finger, a nasal cannula under the nose, and then kind of, you could say, a stretchy belt that goes around the chest wall to look at the rhythm of breathing, rise and fall of the chest. And, rhythm is set up by the nervous system, right? And with that, in many cases, we can diagnose obstructive sleep apnea, hypopnea syndrome, without bringing you into the sleep center. Now, of course, sometimes that it becomes necessary. Sometimes on the basis of other conditions, it has to be done in the laboratory setting. But now, in modern sleep medicine, we have a multitude of options, right? So there's different types of home sleep test devices. Very easy to use, very easy to perform, and usually can get done quickly without delay. So we talked a little bit about snoring at its surface. We talked about, obviously, it may be a warning sign that something more serious is going on. There are a number of disorders that can be related to this, of course. We touched on that a little bit. Obviously, we don't have time to cover like all the bases here. But a lot of questions in clinical practice come about. A lot of people just assume they have it and they come in and want to start talking about treatment options already. And so I get a lot of questions in that area. So I wanted to talk about that a little bit. So I use the term initial treatment options. A lot of the things that are new and available now are not things that you want to consider right from the very beginning. Sometimes some of the newer options, they don't quite suppress obstructive sleep apnea to the point where it's a clinically viable treatment. So sometimes these, not all the time, but sometimes these options are or should be considered after use of initial, right, or first line treatment options. The first line treatment options have high efficacy, very safe to use. And then the second line options becomes a little bit more difficult in terms of side effects and efficacy and things like that. So when we talk about treatment options, really the first thing to figure out is, after the testing is done, where are you or where is the patient on a spectrum of severity, right? And there's different ways to talk about severity. You can talk about it on the basis of what happens with the oxygen levels, right? Most of the disease processes, not all, but most of the disease processes are going to occur on the basis of what happens with the oxygen. Another way to look at severity, and in my mind, it's a simpler, more basic, and maybe less nuanced way, is to just look at the frequency of the obstructions, be they partial or complete obstructions, just the frequency of them, how often they occur on an hourly basis, right? So we start calling it obstructive sleep apnea syndrome once you hit 5 of these events per hour. When you get to 15, we start to call it moderate. And when you're at 30 or above, we start to call it severe. In my clinical practice, however, those numbers can be a little bit arbitrary in the absence of using oxygen as an underpinning to really understand what the severity is. That gives you kind of an idea of how that works. So one option has two names, OAT or MAD, oral appliance therapy or mandibular advancement device therapy. I get this question a lot. So what is this? So this is basically a mouthpiece. A mouthpiece, yes, like a football player or boxer would wear, but the idea here is it's pared down a little bit in terms of size. It only covers the teeth. There needs to be a portion that's upper and lower. And in some way, shape, or form, the top has to be hinged to the bottom, because the purpose of this, of course, is not to protect the teeth, but rather to decrease snoring, pauses in breathing, and lack of oxygenation. In order to do that, this device has to advance the mandible. If you can advance the lower jaw, you can open up the space, and of course the tongue rides with the lower jaw. You can open up the space behind the tongue and open up some airflow down to the lungs. So this is an absolutely viable option. It can be considered first-line therapy in some cases, not all, but some. When you start getting into severe obstructive sleep apnea or high moderate obstructive sleep apnea, or sleep apnea where the oxygen levels have gone down significantly, this may not be a good option. Of course, there are also possible side effects. Sometimes people have issues with temporal mandibular joint pain, clicking, discomfort of the jaw upon opening and closing. There's some comfort issues that are possible as well. This device is made or should be made by a qualified dentist, right? A dentist who is accustomed to making these devices, accustomed to working with patients with obstructive sleep apnea. So not all dentists make this device, right? This is a specialized or a dentist who has additional certification and training. Then there's positive airway pressure therapy, right? So most people call it CPAP, which was kind of the original treatment, which goes back into the mid-'80s. CPAP stands for continuous positive airway pressure, right? Continuous meaning there's one pressure delivered, you're breathing at one pressure level, the pressure is delivered by some form of interface. I don't call them masks anymore because some of them are so small and just sit right under the nose. It's not a mask so much as it is an interface for delivery of air pressure. The designs include options that sit under the nose, nasal pillows that form seals with each individual nostril, go around the nose. But the bottom line for all of these different forms of therapy, APAP, BPAP or BiPAP, CPAP, for all of them, there is a necessity for delivering air pressure. The way this works is very simple. The area of obstruction is behind the tongue and from above the soft palate. But the area of obstruction is the surrounding area. It's all soft tissue. So the idea is if you can introduce a little puff of air or a little bit of air pressure between those soft tissues, and you can get enough separation of those tissues, you can get back to normal breathing, normal oxygenation. This is an extremely effective therapy, extremely flexible therapy. It's the safest therapy you can imagine. You're using a puff of air to fix a very complex problem. The difficulty some people have with it is finding the right pressure settings, and this is where sleep specialists come into play. Uh, Finding the right interface, finding the right type of device, and I'm going to get into the types in a second. Finding the right type of device, and then having someone follow through with you, subjectively listening to what's happening in terms of your experience with it, and objectively looking at data that tells us what's happening as well. With that, we can get to the point where it's fine-tuned such that the obstructive sleep apnea is fully suppressed, and sleep quality is much better, and the all the things associated with obstructive sleep apnea, the disorders that occur in association, in many cases can be erased. The risk factors can be removed. Increased risk of heart attack and stroke, right? Decreased blood pressure problems. So let's talk about a little bit about the different types of these. APAP is automatic, or you could say automatically adjusting positive airway pressure therapy. The idea here is that this is kind of a smarter machine. This machine has the ability to sense what's happening with your breathing and adjust accordingly. So the physician will set the parameters for this, which are flexible and can be changed. But the idea is you set it in the beginning such that the machine has the ability to start with a low pressure, because when you first put it on, you're awake. And as you go through the night, the pressures vary. It's kind of a pressure on demand kind of a system. The machine is sensing you, and it adjusts to what's happening with your breathing through the night. BiPAP, BPAP or BiPAP, you could say. Bi meaning two, obviously, so it's a split pressure. There's a pressure for when you're inhaling and a pressure for when you're exhaling, right? For some people, this is more comfortable. In certain clinical scenarios, it can be important, especially for disorders where disorders of lung obstruction, where there is COPD or asthma. These are disorders of difficulty expelling or exhaling air. Inhaling is easy, getting the air out is more difficult. And so what BiPAP can do is it can bring down the pressure when you're exhaling, such that A, easier to breathe, and B, oxygen exchange is improved. Oxygen CO2 exchange is improved. So that covers kind of the different basic kind of introduction, different types of positive airway pressure therapy. Weight loss is extremely important. I mentioned Zepbound here specifically because I get a lot of questions here. This is a medication that's been approved for weight loss for people who have obstructive sleep apnea, right? So you could say, yes, approved for obstructive sleep apnea, but if you're obese, right? This is not kind of a new idea, of course. As we lose weight, the tissues around the airway recede and the airway tends to open as we lose weight. The reverse is true, of course. As we gain weight, the airway gets constricted to some degree. But there are a lot of medications now, these injectable medications, you've heard of these, Mounjaro and Zepbound, tirzepatide, and various others, that are good at controlling or decreasing body mass, but really only when it's part of a complete and comprehensive clinical program. That program is available here at Valley. Thankfully, we have a medically managed weight loss team. And in addition to just prescribing these medications, they also have a comprehensive plan. If you look at the studies for these types of medications, the success occurred as a part of a comprehensive plan, not just the medication alone. Unfortunately, I see a lot of people who just take the medication and are just hoping for a miracle, I guess. But that doesn't really track with what the studies were trying to show. These medications should be taken, again, as part of a comprehensive program that's looking at body fat percentage, muscle mass percentage, and kind of an established baseline for certain blood work and labs that need to be done. But weight loss alone, in some cases, can not just improve sleep disordered breathing and sleep quality. In some cases, you can get to the point where there's a cure. Your sleep apnea is cured. Now, that's not the case for everyone, because if we go back, if we rewind back to the beginning of this talk, we talked about not everyone has obstructive sleep apnea just purely on the basis of their weight. The shape and the anatomy of the posterior airway, right, is the most important thing. And in some cases, you could have a completely normal body mass and still have obstructive sleep apnea syndrome. But all that said, most of the time, for adults, weight loss can be at the very least helpful. And in certain instances, not the majority of cases, but in certain instances, it can get you to the point, if you lose enough weight, that you can be cured. All right, let's go a little bit further, a little bit deeper now. I think we still have some time. Just to touch upon it just for a second, we talked a little bit about some consequences of obstructive sleep apnea. But the simplest way to look at it is, well, if you have obstructive sleep apnea and it's never treated, and if you look at a cohort, a group of people who have sleep apnea and don't treat it, well, simply stated, their lifespan is shorter. We call it all-cause mortality. You have to call it that because the causes of death are multitude. Again, this is a syndrome that can affect multiple organ systems, right? So that's something that's been known for quite a few years. Now, the good news there is for people who treat their obstructive sleep apnea, right, they can get right back to normal levels of lifespan on the basis of treatment. So cardiovascular disease risk can be significantly elevated with obstructive sleep apnea. Now, this includes quite a few things: circulation, blood clot formation. We're talking about heart attack risk, of course, but also arrhythmias, right? There's nothing more irritating to the heart than low oxygen. During these periods where there are pauses in breathing, what we call the intrathoracic pressure, negative intrathoracic pressure rises. So the simplest way to describe this is during the event, after we finish exhaling, the airway closes. The brain still sends a message to the muscles to pull air in again, but the airway's closed now. So what ends up happening is you do what's called a Mueller maneuver, where pressures are going up, 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 and it's almost like a squeeze effect on the heart. So you have now a mechanical pressure being placed on the heart, and you've robbed the heart at the same time of something essential, oxygen. And this can trigger a multitude of things, from changes in the heart muscle itself, where there's a negative adaptive response, or the triggering, or I should say, the triggering of arrhythmias. Lack of oxygen to the brain, not a surprise, I guess, could result in many cases, results in early dementia, right? Alzheimer's is one of those things. So there's great work and studies and research being done in this arena, showing these connections. There's a part of the brain during one of the stages of sleep I mentioned, where there's something called the glymphatic system. So we all know what blood vessels are, arteries and veins that carry blood back and forth. There's also a lymph system, right, that carries immune cells and fluid in different areas of the body. The brain has its own setup for this, whereby during sleep, the things, the little proteins, and you could call them toxins, I guess, that build up due to activity of the brain cells, right, over time, as we're awake and we're thinking and we're using our brain, we build up waste in the brain, literally build up waste in the brain. Sleep, right, through this lymphatic system, drains that waste away. In the absence of normal and proper sleep, these toxins and proteins and things build up and promote early dementia. And so this is a very interesting area of study. Parkinson's disease is another, and also another area of study. Cancer risk seems to go up significantly with obstructive sleep apnea syndrome. Running a little short on time, we're going to move forward quickly here. Inspire implanted device is another one that people get have a lot of questions about. This is basically a pacemaker for tongue muscles. The device is implanted in the chest, similar to how a cardiac pacemaker is done. It doesn't fully suppress obstructive sleep apnea syndrome, but if you get an 80% reduction in the frequency of pauses and breathing for that device, that's pretty good. But there's very specific criteria for this in terms of age. You have to have failed prior or failed primary therapy, which is positive airway pressure therapy. You can't have concentric airway collapse, right? Concentric collapse, which this device doesn't seem to work well with that. If you have too many central events, in other words, events mediated by the nervous system itself, as opposed to just obstruction, that's not a place where you want to be using this device. Here's a little illustration of that device. On the bottom, see sensing leads. It's looking to figure out what the timing is for breathing, to figure out when this generator can send stimulation to the hypoglossal nerve. The idea there is you want to time it such that the muscles here are helping to open the airway, right? Again, this is a pacemaker for breathing, you could say, and opening the upper airway. Target anatomy, hypoglossal nerve, and you can see some of the muscles that the hypoglossal nerve target. This is a nerve here, hypothalamus, and then connecting to muscles of the tongue. Genioglossus muscles, hyoglossus, styloglossus, and some of the intrinsic muscles, the muscles we use to kind of change the shape of our tongue. Surgery is another option. Now, there's a picture of a child here for a reason. Most of the time, obstructive sleep apnea surgery is reserved for the pediatric population. And that's because we're dealing with small, very small airways, but adenoid tissue and tonsillar tissue that can be very large, relatively speaking. And so what happens is, most of the time, let's say starting from the age of even 18 months to 2 years old, you start to develop this immune tissue. It starts to grow in the airway, and it can get to the point where it's blocking and causing obstruction and true obstructive sleep apnea syndrome. So young children can have this disorder, and it can be really destructive in terms of development. We don't think of it always, but there's also could be cardiovascular consequences where children can start to develop high blood pressure, believe it or not, on the basis of it. But for the most part, the biggest thing it causes is major derangements, or can cause major derangements in development. Occasionally, adults will have large tonsils. But the question is, are they blocking the airway enough where removal would cause or lead to relief, or enough relief, complete resolution? So here's a picture of, you can see the uvula, right, hanging down, giving us that little M shape in the back of the throat. The tonsils pushing laterally into the sides of the airway. Tonsils this size or larger, once removed, can actually improve sleep apnea significantly. There are other surgeries that are done. Let's say adenoids and tonsils are normal size. Some people have gone for something called UPPP, uvulopalatopharyngoplasty. It's a long name. But the idea there is you cut out the uvula and the surrounding soft palate tissue such that it can't fall down onto the back of the tongue. But if you really do a deep dive into the data, that surgery in the long term can be problematic, and in some cases cause worsening of obstructive sleep apnea. Very painful surgery. I don't tend to recommend that. So in summary, we have some time for questions at the end. Yes, snoring itself, all by itself, is just noise, but it can be a major warning sign of something more important going on. So we've got to think about discerning and separating snoring from this obstructive sleep apnea hypopnea syndrome. Screening tests are done easily, and in many cases can be done at home. There's a multitude of treatment options, depending on type and severity. By no means did I cover all of them. Bottom line, sleep well. Your health depends on it. I'll end here just to give us some time for questions.
Okay, so cute. Thank you, Dr. Dixon. That was great, so comprehensive and interesting. There's a few questions, if that's okay, Dr. Dixon. One of the such questions is, just wanted to get an opinion of like Apple phone sleep analyses, like sleep cycle apps, if you have any input on them.
Right. I think of these Apple watches and devices similar to snoring. If you have one and it's saying, or there's a warning going off, please get checked out, you may have sleep apnea, then yes, you should do that. In terms of the accuracy of these things, it doesn't really match up that well with laboratory testing or the most rigorous forms of testing. I would say don't use it as a diagnostic device, but more like an early warning system, right? Whereby it tells you, well, maybe you might want to get checked out on the basis of what it's saying.
Okay, great. Let's see, is there any possibility for a person to measure their partner's O2 level with like a finger reader in the middle of the night to see if their partner, okay.
Yes, but here's the problem. There's something called oxygen sampling rate. So a lot of the things that are available commercially in terms of figuring out what's happening with the oxygen, sampling rate refers to how many times the device is looking and sampling the oxygen, right? The medical level devices can pick up drops in the oxygen, right, that other devices cannot, right? So I understand the idea there, makes sense. But if you're not using a medical grade device, you're leaving something out. The other part of it is there are other reasons for oxygen levels to drop. And then a key piece of this is where's the drop in oxygen coming from? Is it coming from the nervous system, or is it coming purely from obstruction? And this is why you need to discern that to figure out what to do about it. But if you want to consider something like that to coerce someone who says, it's just snoring, it's not a big deal, it's just a little bit of noise, leave me alone, and you test and you see, well, the oxygen's going down, it could be useful. The flip side of that coin is if it's not showing big dips in the oxygen, right, you get the opposite effect.
Right. So a couple of like sort of home remedy questions, like, first of all, does keeping your head elevated help, or does magnesium help, or any particular vitamins help with these issues?
If we're talking purely about snoring, right, noise that's happening, body position can change the intensity or loudness of snoring. Sleeping on your back, face up, supine, we call it, causes the gravity to kind of take over. The tongue gets pulled down into the airway and can cause more snoring, right? Sleeping on the side tends to be more beneficial. But what you don't know when you're sleeping on your side, are you now, instead of having apneas and snoring, are you now having hypopneas partial airway obstruction, where it sounds better, but it's still a health problem. That's hard to say. But generally speaking, sleeping on the side better than sleeping on your back.
Okay. Somebody's asking